हेलो। 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 Good evening, everyone. Okay. Good evening, everyone. So let us start moving towards the opening of the session. As all of you know, Medical Pharmacology Society is a society established in 2016, and it has been serving medical pharmacologists and all types of pharmacologists through various programs. We have been conducting series of webinars. Successfully, we have conducted 4 webinars, and this is our 5th webinar. And thank you so much. Thank you very much for your continued support. We have reached more than 1,500 people, in fact 1,600 people in our WhatsApp group, and we have received nearly 2,800 registrations since we started this webinar series. And the success story is continuing just because of all your support and your interest to learn. As all of you know that we should continue to update our knowledge continuously. Then only we will be able to improve in whatever we are doing. So with this interest, I believe that all of you are joining and supporting our programs. We thank all our speakers, right from Dr. Suyog Sindhu, Dr. Sapna Patil, Dr. Padmaja, myself, and Dr. Jita, who all have already contributed to our program. Now, today, we are having Dr. Gigi. She is the assistant professor and also PhD scholar, currently working at Purti College of Pharmacy, Bangalore, Karnataka, India. She has come forward to present a topic on Drug Information Center, Operation Insights, and Best Practices. Most of the pharmacology departments, they want to expand their services to patients, clinicians, and to various wings of hospital, with the objective to provide the clinical services in pharmacology, and we all strive together to make the pharmacology department a service department. Most of the medical colleges and pharmacy and other colleges who are teaching pharmacology, they are working as teaching institutions, but we all want to do some kind of patient service, and this is the one of the most important ways through which we can do patient service by providing drug information services. So fortunately, we have Mrs. Gigi K. She has come forward herself. Actually, I am very happy to say that she volunteered and she sent a mail and she requested for this topic. And she prepared and informed me that she is ready. And now today we are on call to this webinar to present this topic. So I would like to congratulate Gigi for this achievement of securing this opportunity to present the topic. And now I would like to introduce our chairperson, Dr. Basavanna. Dr. Basavanna will be our today's chairperson. Let me introduce. Dr. Basavanna sir is an MD Pharmacology with so many additional certifications like CCE, DGM, CGD, CGD, HHM, like this. And he is currently serving as Professor and Head, Department of Pharmacology, Mysore Medical College and Research Institution, Mysore, Karnataka, India. He also worked in various capacities like Coordinator, Pharmacovigilance Center, MMCRI, State Nodal Officer, Material Vigilance Program of India, Nodal Officer, Ayushman Digital Mission, National Medical Commission, then NMC, National Medical Council, then Nodal Officer, Digital Mission Mode Project, MCI, New Delhi. And he is also, for a short while, he also served as a principal at MMCRI and Vice President, currently also is Vice President of People Association of Geriatric Empowerment, Mysore. So we are very fortunate to have him with us today. So I'm just trying to check whether sir came online. so that we can go ahead with the program. Sir, have you joined? Join Madi, sir. I have introduced you already. Baswana sir is coming online in a few seconds. So many people have said good evening. Thank you everyone. So let me read out Aditya Kumar Yadav and Girisia. Imtiaz Girasia, co-founder Innovation Clinical Research Center, Vadodara. Then we have Priyanka Ramanuj, Betty, then Archana Nipani, so many people, Dr. Jayaprakash Chaudhary, Dr. Sindhu Kesi, Archana, Dr. Prashant Mali. So thank you so much everyone for joining online. So in the meanwhile, I'm just waiting for Dr. Batwana sir to come online. So Dr. Rujul Bahekar.
Hello.
Yeah. Yes, sir. Please join, sir. Okay, sir. Sir, I just introduced you. So Dr. Batwana sir is here. As I already told you, he worked as an ex-principal of MMCRI. He is the Vice President of People's Association of for Geriatric Empowerment, Mysore, Nodal Officer, Digital Mission, Board Project, NKI, New Delhi, Nodal Officer, Ayushman Digital Mission, NMC, State Nodal Officer, Material Vigilance, Program of India, Coordinator, Pharmacovigilance Center at MMC, and he is currently working as Professor and Head Department of Pharmacology, MMCRI, Mysore, Karnataka, India. Sir, it is over to you. So you can start, and then I will project Mrs. Gigi's profile, and meanwhile you can also continue with that.
Yes, thank you, Sumurthy. Thank you.
Yes, sir. Please go ahead, sir. Go ahead with the yes.
Okay. Thank you. Yes. Thank you. Today's speaker is. I'd like to introduce today's speaker. First of all, I'm sorry for the little bit delay in joining because today we are celebrating. We have completed 25 years of service in Mysore Medical College. So that's why we are a bit late delay.
Congratulations, sir. Congratulations.
So 25 years of service in Mysore Medical College itself. So totally out of 30 years of service. So in MMCRI itself is so our noble institute. So that's why.
Sir, we wish you many more years to go ahead with your service at.
Thank you so much. Thank you so much. Meanwhile, before I'll introduce about speaker. So drug information center. I would like to talk few words, a few sentences. Is it okay?
Yes, sir. Yes, sir. Please go ahead.
So I'm the. Initially, like you or like anybody in the pharmacology department, we all also struggle to expose to clinical side, clinical aspect of. So we are just moved slowly from 2018. Then by the time of 2020, I started one drug information center in Mysore Medical College. That is in the care hospital. That's world oldest hospital in Karnataka. It's about 100 years ago. It was established by our Highness Mysore Maharaja over there. There I have established one drug information center. It mainly to cater the in-house patients, that is inpatients, about how to take medication. That mainly about drug complaints. What are the drugs they are taking it? what for they're taking it, how to take, and how long, and all those, that is dose, duration, all there with everything. And if there is any adverse reactions, please, we are asking them to report immediately so that our pharmacovigilance data will all be available. So main intention was to establish is to enhance the complaints of the in-house patient, that inpatients of the care hospital. Then it was catering to a public at large, whoever come to the drug distribution center. There we are started counseling through Pharma D students, and MD Pharmacal students about those, about whatever the commonest over-the-counter drugs, what you mean by over-the-counter drugs, and what you mean by prescription drugs, and what the prescription only drugs, like that. So we have started highlighting and the one-to-one and interactions initially. If there is any queries, will be talking easily. So there we are clarifying the doubts. So that is about mainly their patient safety. Our concern is main to the safety of the patients. So with this safety narrative, we are gone into giving the information. Sometimes maybe orally, sometimes they have for some small leaflets. So usually give the handouts also. And then the clinical trial people, right?
Yes,
The
sir, please go
investigators,
ahead.
they are asking about new drugs. So for them, we are giving recent literature, all those things. So this was like going on, and still it is able to manage a little bit with, because now the hospitals are number of hospitals are increased under MMSRI. It is difficult to cater all the populations, so it restricted only care hospital. So it is going similar. So meanwhile, I would like to introduce the speaker, Miss Gigi K. She has completed M Pharma pharmacy practice. She was currently working in assistant professor, Spurti College of Pharmacy, Bangalore, and she has a PhD scholar in pharmacy practice in from Aditya Institute of Pharmacy College of Pharmacy, Mandya. That is Belluru, Bijanagara, Mandya, and then worked as a drug information center in charge and Equa International Hospital Research Center, Calicut, Kerala. And she also worked as an internal auditor at for NABH, that is quality control, as a quality control member, and then PTC member, the speaker at various national and state conferences, and published some few original articles, review articles, case reports in indexed and peer-reviewed journals. Thank you. Over to Ms. Gigi K.
Okay, Gigi, Gigi, can you hear me?
Yes, sir.
Okay, so I have stopped the sharing. So now you can
Okay.
take over, share the your screen as we discussed. Please go.
Okay, sir.
Yeah. Go to presentation mode.
Is it visible, sir?
Yes, it is visible. You can go ahead.
Good evening to one and all. Thanks for the wonderful introduction, sir. And special thanks to Dr. Shivamurthy, sir, for giving this wonderful platform and opportunity for me. Today, I'll be talking on Drug Information Center, its operational insights and best practices which we can follow to develop a drug information center. Moving on. So, first, we should know what is a drug information center. So, here I have defined the drug information center as they are the specialized unit which is set up in a hospital or an industry or maybe a teaching institution so as to provide accurate, unbiased, and evidence based information. So, here I have highlighted the three words like accurate, unbiased, and evidence based. So, keep in mind, like all the information which we are sharing through a DIC should be clear, unbiased, and evidence based. So, we'll be keeping these 3 points in mind as we are moving forward with the slide. And DICs provide information related to medicines to the healthcare professional, patients, and to the public. So, the main aim of any drug information center is to safeguard the patient right, to protect the patient, to ensure the medication safety, and to assure like no medication errors are happening from our hand regarding to the drugs. So, coming to the historical evolution of DICs. So, it was in the year 1962 where the first drug information center started in USA at the University of Kentucky. And the wonderful thing about the US was that they started in 1962, and by the year 1980, means within a within a 20-year period, they developed almost 127 functional drug information centers. So that is something great to be spoken about that country. And their aim was to promote rational use of drugs, means they aim to establish the DICs so as to promote the rational use of drug and to provide services on drugs, like to provide counseling and awareness on medication usage. Coming to in India, like 1970, the India's first drug information center was established at Christian Medical College, Vellore. Later in 1995, the National Poison Information Center got established at AIIMS, Delhi, and in 1997, the Karnataka State Pharmacy Council established the DIC, which was a well flourished DIC where they aimed to provide patient service in Bangalore. And to tell the truth, in 2025, when we are standing in 2025, we just have almost 36 centers only in India to spread the awareness, to give the education related to drugs. So that is actually one of the drawback of our country. We know, in the market, a number of formulations are available, but still we are lagging behind drug information center. And so we'll be moving forward. What are the steps we can use to develop a drug information center in India, and how we can make our country also flourished and to provide resources related to drug. Now, what are the core components of a drug information center? Means, if you are planning for starting a drug information center, what are the things to be kept in mind? So, we need a clinical pharmacologist or toxicologist whose service is especially needed to provide expert insights about the therapeutic and pharmacological action of drug. Without a clinical pharmacologist, we cannot start the DIC, or a guidance will be lacking if a clinical pharmacologist is missing. So we need a clinical pharmacologist who is an expert in clinical field and drug related pharmacological and therapeutic effects to explain to the patient. Second one is the clinical pharmacist, maybe with the qualification of M.Pharm pharmacy practice, or M.Pharm pharmacology, or even PharmD graduate, who can lead query handling and literature evaluation and take parts in answering the drug related queries and even the patient counseling. Now, the third group is pharmacy interns and resident, where they assist the clinical pharmacist, they help in data collection and documentation, and they do learn and practice so as to create awareness, and they are the budding clinical pharmacists for the future. And we need also the supporting staff like IT personnel, administrative assistants, and the library science people. Now, we told in the first slide I have discussed, DICs provide unbiased evidence based information. So from where do we get this information, or what are the sources which provides the drug information, means which gives us the drug information? So I have categorized them into primary sources, secondary and tertiary sources. So primary sources, I would define them like they provide the most up to date or most relevant on hand information. They include randomized control trial studies, case report and case series, even clinical studies published in highly peer-reviewed journal, and the original conference proceedings. So these resources are termed as primary resources, and we can obtain information pertaining to the drug from the primary resources. Now moving on to the secondary sources, they include index, abstract, and organized primary literature. Means we develop it from the primary sources. We have the PubMed, Medline, MPS, Cochrane Library, International Pharmaceutical Abstract, and often Scopus and Web of Science Index journals. Coming to the tertiary sources where we use our books to define the question or to confirm the answers. So there are various textbooks like Goodman and Gilman, Lawrence and Bennett, drug compendia like Sims, Medscape, Drugs.com, formularies, pharmacopoeia, treatment guidelines established by World Health Organization and drug bulletin. So all these resources should be made available for the DIC. A DIC should have access to all the primary, secondary, and tertiary resources. Then only we can have a well established or a well functioning drug information center. So, the other resources I would like to add here the pharmaceutical database. So, from my experience, what I have found is like often the pharmaceutical databases like Lexicon, Up to Date, etc., provides us the up to date information related to the drug. Means they define everything related to the drug in terms of the dose to be administered, that too in different population like geriatric, pediatric, special care needed population as per like the dose adjustment as per the weight of the patient if the patient is with any comorbid condition, for example CKD patient on dialysis. So in that cases this resources give very accurate information, so it is mandatory for the DICs to have an updated software which is available every time and which is accessible to the pharmacologist and the clinical pharmacist in the drug information center, and it should be updated like the subscription should be updated and renewed and it should be made available at all times. Then along with that we can use other search engine like Google Scholars, ResearchGate, Biblimed, WebMed, but I would suggest and I would focus on Lexicon and Up to Date because like they do provide more relevant information. So if we are getting a query, these resources makes us easy to understand the query or to means to clarify and to rectify the answers. Now, infrastructure, we talked about the resources which should be made available. So, along with resources, we need the infra also for the drug information center. So, there should be a proper dedicated space. So, if it is a hospital, means the if the DIC is functioning in a hospital, it should be located possibly in the ground floor and near to the pharmacy so that the patient can easily access the DIC service. So there should be a well defined place and it should be set up in a peaceful atmosphere such that means like not in a crowded environment. So we aim to provide patient counseling, right? So if it is in a crowded environment, the patient may not be having or he may not get the concentration or the attention to pay to us when we are explaining about the drugs. So there should be a particular dedicated space for the DIC. And we need high speed computers and internet services, which is available always when the DIC is functioning. Since I told about the resources, these resources are like nowadays all are dependent on online sources. It's not like we should not trust the book. The books are the main informative sources we all learn by referring a number of books. So always we have to depend on the books, but again whatever like books the limitation is like they can't be updated always, so we use the online sources to get the updated information. So for that purpose we need high speed computers, internet, and a good drug database with proper subscription. Then telecommunication tools should be available like phone, fax, and email. Phone is very essential, and this number should be shared to the patient and the public so that they can access our service or the DIC service whenever they require. This telephone number should be made available to the people, patient, and even the healthcare providers. Then we need space for storage of document like any meetings or any queries or any patient counseling which happen in a DIC should be documented. So we need proper documentation and obviously furniture for consultation and for training purposes. Now, different types of DICs. So, initially I said like hospital DIC should operate near to the pharmacy. So, we have other different types also like academic DIC, hospital DIC, institutional, and even industry DIC. So, academic DIC means they are the drug information center which operates in a pharmacy college or university, and their main area of focus is to provide education, training, and research for the upcoming clinical pharmacist or pharmacologist. And whereas hospital DIC, they operate with hospital premises, as I stated before, preferably near to a hospital pharmacy, and they mainly focus on providing patient counseling, managing the formulary, especially the drug formulary, then taking clinical decision and support to assist the doctors or physicians in terms of clinical related matters. Institutional DIC, which operates under NGO, government bodies, and association, they focus mainly on the public health and to make policy. For example, if there is any epidemic spread in an area, they focus to implement the policy to provide attention for the public and to minimize the risk of diseases and infections. And industry DIC, which operates in the pharmaceutical companies, and they concentrate mainly on product information and regulatory related compliances. Now, let's move to the drug information center in detail. I hope everyone is clear about the resources used and how to set up a DIC. So, after setting up the DIC, we should know what are the functions or what are the operations that is to be carried in the DIC. So, here I have given the title We Share the Story of Medicine. So, does medicine have any story to share with us? Why such a title? So, see, in our country, we have almost 60,000 generic drugs. So, think the number of drugs is increasing. So, and the patient, the disease, different infection, different organism, everything is increasing day by day. So, if the patient is using the drug without proper information, without undergoing a proper drug information counseling, how he can get a better treatment outcome? Especially, see the case of antibiotic. If we are not educating the patient about the importance of completing his course, will he take the drug? And again, the still problem which persists, antibiotic resistance. So, I believe to a great extent, if we are educating the people or the patients on how important is their medicines, we can solve the problems of drug resistance. Even many medication errors also can be minimized. So that's why we share or the DICs share the story of medicines. Now, talking about the services offered at DIC. The DIC offer, or from the DIC to the clinical pharmacist and clinical pharmacologist, offer different services like patient counseling, medication adherence, answering drug related queries, prescription audit, medication error monitoring, medication reconciliation, pharmacovigilance, which is related to the ADR reporting, providing training and education, and antibiotic stewardship. So, we'll move with the patient counseling. So, patient counseling is the most important responsibility of a drug information center. That is to provide information, advice, and assistance to help patients so as to use the medicine safely. So, as reported now, medication errors are the third most common cause for death of people. So, how can we minimize the medication error? If we are educating a patient properly, the medication errors also can be minimized. Now, like we know, like a patient comes to a physician, the physician prescribes diagnosis and prescribe the drug for the patient, but always the physician may not have the time to speak and communicate everything related to the drug to the patient due to his busy schedule, and even he focuses on patient care. So like he has to treat the people, there will be a time set, there will be a goal set. So there are limitations for the physicians to always educate, sit, educate, and make them understand. So the patient will be directed to the drug information center after undergoing the physician's consultation. So the patient visits the DIC where the clinical pharmacist or the pharmacologist counsels on the importance of each drug prescribed to him. And before counseling, we have to assess the knowledge of the patient. Right, right now, because like, see, if the patient is not from an educated background, to use the common colloquial language instead of using medical terms for the patient to explain, which makes him easy, comfortable to understand about his medication. But you see, this is current situation of the counseling. Okay. Uh, any idea from this picture? I would like to describe it like, see, uh, even think us as a patient, we are visiting the hospital, and first in the morning, if we are going by 10 o'clock, the first department which we visit is the means like where we'll do the registration. We'll register or we'll take the appointment for the doctor. We pays the fees, everything. We get the appointment. We goes for the OPD department. We waits in front of the OPD till our turn arrives. So after that, again, we will visit the doctor. Doctor diagnoses the disease. Doctor prescribes for us, or maybe like if a blood test or any other tests are required, he orders for a test, maybe blood test, maybe X-ray, maybe an MRI, or whatever test it is. And again, the patient moves to the next department, maybe the lab, uh, where he get the laboratory services. After getting the result, again he revisit the doctor. Then the doctor prescribes the drug. After prescribing, maybe again the doctor directs for a physiotherapy treatment or any other therapy which is to be done. Again, the patient moves there, and at the last, the patient come to the department called the pharmacy. So by that time, the patient will be too much tired. The patient may not be having the patience to listen to the advices of the clinical pharmacist or the pharmacologist regarding the drug. So often, what I have found from my experience is they are in a rush to reach the home. They will complain always, we came early. Now, no time to read about the drugs, or we don't have time to sit and discuss about the drug. But many accidents and incidents, that is, medication errors, have occurred because of this attitude of the patient. So, always it is mandatory, it is very much mandatory, I would tell, to refer the patient to a pharmacologist or the drug information center where the clinical pharmacist counsels the patient on the importance of drug, not only the importance, how to take the medication, what are the drugs to be avoided while taking this medication, what is the diet to be maintained while we are following this medication, and when to do the follow up. Is a follow up required? What are the things to be monitored? Where is there any chance for adverse drug reaction to be precipitated because of so and so drug, etc.? So it is very much mandatory to attend patient counseling. Means the patient himself should present to the DIC with his prescription and the drugs obtained from pharmacy, and should get educated about the drugs before leaving the hospital. So here I would like to share a video.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you have to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Jerk. What was that all about?
Jamaican chicken recipes.
So I hope you have understood from the video. Like this is not a comic. It is the actual situation which happens with patient. Like patient thinks like they are the kings or queens of the medicine, and they decide how to use. So here in the video, the doctor has prescribed an inhaler for the patient. And the way the patient use, even I have seen many patients who visited in the DIC, like inhalers, they don't spray in the mouth, maybe nasally they'll take, or like even though they spray or they use through the mouth, but the way they take the inhalers, and like many areas developing, like they don't wash the mouth after using this oral steroid, and ulcers precipitating in the mouth, and again coming back to hospital or to the physician complaining like my medicine didn't do any miracle and I am still suffering of this. Okay, so hope you have understood the importance of patient counseling. Now, different types of patient counseling. First is clinical and medication related counseling, where we can emphasize on the medication usages like dosage, timing, when to be taken, then side effect, interaction, what are the interactions to be kept in mind while using a particular drug, and even the storage. I have seen many patients like they don't store insulin properly. So, as per the specification, insulin, there is a particular temperature to be stored, and we have to keep it refrigerated. But no one is worried. Like, and not only that about insulin, the use of syringe, like disposable syringe. Once they open the insulin vial, they uses the syringe till that vial is empty. So, like without knowing what is the importance of changing this syringes used for administration, they continuously use it and they meet up with some infection. But it may not be noticeable in the first stages within 1 month or 2 months. But I had a patient 6 months. After 6 months, he came with a complaint like I have developed full blackish color on my site where I administered the insulin. We asked like what happened, how you were using the insulin. Can you teach us or can you tell us back how you were using the process, or like in what way you was using? Then he said, yeah, one needle I use for one bottle till one bottle is dead. Then we asked like, don't you feel pain? How you feel? No, no, it's okay. The cost is more, so I can't afford. So this was the answer. But when I counsel him about the importance of that changing the syringes and it's for one time use, he was like, no one informed me about this. From last 6 months I was using the same thing, but no one has said me anything related to this. So see the importance of counseling. Now in case of chronic disease management like diabetes, hypertension, asthma, then antibiotic stewardship, where we emphasize and focus on completing the course of antibiotic and not deciding the antibiotic by the patient. So often the patients how they'll convince like I took the medicine myself for 1 week. I didn't find any improvement in my condition and I came to see the doctor. Then we used to ask like, okay, who decided the medicine for you and or how you fix the medicine? How you decided the medicine? Yeah, antibiotics I took. I know azithromycin will work for this URTI. So means like maybe some cold cough. So I know like or my cousin was having the problem of same cough and sputum production was there. He took azithro and he got relief. So patient himself is judging their treatment. So here again our importance come where we can counsel and where we can assist the patient to educate him regarding the importance of proper medication use. Now, adverse drug reaction. How an ADR can be recognized to promote the reporting of ADR and management, and especially polypharmacy, where the patient may be on multiple drugs and without knowing the interactions and without knowing a proper diet to be taken with all such medication, patients continuously take the drug and result in some medication errors. Now, just I want to speak about an example where I have seen many patients using insulin wrong way. Means the doctors suggest the insulin should not be administered at the same site. So, as shown in this diagram, these are the area where insulin is to be administered. But lack of counseling, lack of knowledge makes the patient misleading and they administer the insulin at the site which is comfortable for them. Not which is right, but which is comfortable for them. So I have seen a 70-year-old patient with belly fully black in color and like couldn't define what was the condition. So 70-year-old and along with him his grandson came as the bystander, and when we asked that bystander, he said that my grandpa only is administering the insulin, he administers by himself, and the thing was that his convenient site of administration was the abdominal area and he used to continuously administer on the abdomen. So what the condition precipitated out was got lipohypertrophy, means the subcutaneous tissue lipid accumulation happened and the level of insulin which was used to treat his diabetes level became insufficient. And the thing is like he was under the doctor for 2 years, under the same doctor for 2 years, and now he complained like I lost the trust on my doctor because my insulin is not working on me. So it's not the trust about the doctor or it's not the losing the trust with the insulin, but whenever the patient is using insulin, it is mandatory to do the site rotation. We have to leave at least a 1 centimeter gap between the sites of administration. So as stated in this diagram, you can see like if the patient is administering continuously at the same site, lipohypertrophy develops and the patient later become resistant to the insulin such that the dose may not be sufficient to meet up his blood sugar level. And again, the complaint comes on the doctor or the medicine, like medicine is not working for us. But the lack of counseling or the lack of education has paved way for this. Now, counseling, next one, which is related to the diet and nutrition, where we can tailor plans for weight management, diabetes, and CVD risk. But here, like even the nutritionist or dietitian has a role, but even we too have role. See, for example, if the patient is on warfarin medication, we have to counsel the patient on the importance of cutting vitamin K rich foods. So again, drug and food interaction comes where we has our role to correct the patient, to advise the patient, and to check on the diet taken by the patient. Physical activities like based upon the age, condition, and goals, we can advise the patient to engage so that he can reduce the risk of lifestyle diseases. Then in smoking cessation, behavioral strategies, nicotine replacement support groups, alcohol moderation, and even in sleep hygiene. Then the next category is the special population, where special care should be taken while counseling, like pediatric and geriatric. So often pediatric and geriatric, we cannot counsel and we cannot achieve a 100% satisfaction result for this population. So we have to educate, we have to teach the bystanders, and we have to provide leaflet and pamphlet related to the use of drugs or use of devices or whatever is necessary. Then on pregnancy and lactation, special monitoring is required to monitor the drugs prescribed and how they are taking the drugs. And even adolescent health, where sexual health, mental wellness, and peer pressure groups should be addressed. Now, disease specific and procedural counseling. Here, the great example is pre and post operative care. So there are certain drugs which should be stopped before the surgery. Okay, so the patient, for example, if the patient is on aspirin, at least 1 week before surgery, we have to stop the drug for him. So we have to inform the patient about the risk of aspirin if it is taken for a surgery. And warfarin. Warfarin, if the patient is taking warfarin and if it is he is going for a minor tooth extraction also, it is a great risk. So we have to emphasize the importance of this drug. We have to give the cautions to be checked on before doing some procedure. So all these situations require a great attention of clinical pharmacists. Then in cancer care, where treatment options, side effect is to be monitored, and even emotional support can be given through counseling. Then in case of antiretroviral therapy adherence for HIV patients, then tuberculosis, especially DOTS adherence, the importance of adherence, and there are chances for many ADR to be precipitated while on DOTS therapy. So we have to educate the patient such that he do not stop his medication in between, whereas he continuously adhere to the treatment and moves out of the TB. Now, medication adherence. So, if we are doing proper patient counseling, the patient will surely adhere to the medication. So, better patient adherence to the medication result in better treatment outcome. So, every scenario which we have or I have seen in my experience is like patient once he is not adhering means he just blame the medicines or he just blame the physician, that's it, and he leaves it off. So once we educate the patient on the importance of his medication, on the importance of using the medical devices properly, example inhaler, glucometer, insulin pen, etc., then the patient will stick on to his treatment or the guidelines given by the doctor, and he complete the course, and which result in better medication adherence. Now, next great important thing or the most important thing to be addressed by the Drug Information Center is answering drug related queries, where we can utilize the resources we mentioned earlier, that is the primary source, secondary, and the tertiary sources. So, these are the steps which are coming under answering a drug related query. I will explain this with a good example. Let's move on. See, so these are the steps involved in answering a drug information query. So, how do we receive the drug information query? This drug information query can be from the side of the physician, from the side of nurse or any healthcare provider, or maybe from the patient, or maybe from the public. So, anyone has the right to address his queries to the Drug Information Center, and the duty of the staff involved in the DIC is to rectify and clarify the answer. As we stated, we have to give a well defined answer and not created one. So, we should refer the sources such that the information is accurate, unbiased. Okay, so the first step is, see, to the Drug Information Center, maybe through the phone, we are getting a query. A nurse calling, the example is a nurse calling, asking about IV compatibility of a pediatric patient. So, the first step is secure requested demographics. See, the first is secure requested demographics. So, we have to check who is asking the query. So, here identify who is asking the query and their background. Why we should see their background? See, if the patient is from a medical background, we know the level of knowledge. If it is a common public, we cannot use medical terms or we cannot speak to him in medical terms to get further questions from him. So we have to check the knowledge of the patient and who is asking the question, so that we can provide the answer in the best possible way. So here the example is the nurse calls to the drug information center and she want to check whether that is to check for the IV compatibility, and that too for a pediatric patient. Okay. Now the second step is to obtain background information. So we have to gather all the clinical context, the patient detail, and how urgently she need the response from us. Okay. Some queries we can take time, but some queries maybe within minutes, within 5 to 10 minutes we have to reply back to them. So we have to get all the information while attending a query. So here the child is 3-year old. So the nurse has given the detail. The child is 3-year old, the pediatric patient, and the weight of the child is 12 kg, and he is already on ceftriaxone. And nurse want to check whether paracetamol IV can be given along with ceftriaxone. So the compatibility of ceftriaxone and paracetamol is to be checked for IV route. Okay, now the third step is determine and categorize the question. So we have to categorize the question, means whether the question is related to poison information, whether it is related to any adverse drug reaction, whether it is related to interaction, dosing, whether it is related to the dilution of any drug, the storage of any drug, such that. Okay, so here the query is pertaining to the compatibility and interaction. We have to see whether any interaction exists between paracetamol and ceftriaxone. So compatibility and even the dosing for IV paracetamol for a 3-year-old patient with 12 kg weight. So we have to develop the strategy. That is a 4-step: develop strategy and conduct the search. So we use the resources to conduct the search. So here we can use Micromedics or PubMed for pediatric studies, or even databases like Lexicomp and UpToDate, which give relevant information. And the outmost thing is, whatever information we have collected should be confirmed with the senior pharmacologist before we deliver the answer to the patient. We have to the patient or to the nurse or to the healthcare provider, we have to do double checking before delivering the answer, because they trust us and they are depend on us, and with our proceedings only they will chart the drug. So again, an error should not be created. Now the next step, fifth one, is to evaluate, analyze and synthesize. So we will check with the senior staff, we will check the resources thoroughly, and we determine the answer. So here it is, paracetamol IV is compatible with ceftriaxone, means after using the resources or the sources of searching, primary, secondary and tertiary, we have found that it is compatible, and we have to administer the dose of 15 mg per kg. And since this patient is having 12 kg weight, it's approximately 180 mg. Formulate, next step is formulate and provide response. So this is again very, very important. We have to reply back to them such that they understand what we are saying. So, as we stated above, if it is a healthcare professional, we can use the medical terms or whatever is needed. But if it is to be addressed to the public or the common person or a patient, we cannot use complex medical terms or complex languages. Instead, we have to use the colloquial language such that the patient understand it clearly. So here we can inform the nurse like it is safe to be administered, and the dose is 15 mg per kg every 4 to hours can be given. This is with pertaining to the paracetamol IV. Even we inform the source to the nurse. Okay, since it is a healthcare professional, we can inform the source also. Okay. Now, follow up and documentation. At the end, we have to register this query to the DIC register or the logbook, and that mentioning the time, who asked the query, from which department, and what response was given. And also, we have to add the resources which we use for getting the answer. Now, here we have a case. A female patient of age 60 years, she was admitted to pulmonology department with breathlessness and high grade fever. and she is already a non-case of non-case of asthma, means she is already an asthmatic patient, and she is already having some other comorbid condition like type 2 DM, hypertension, and chronic kidney disease. Okay, and when she was admitted to the hospital, the creatinine level was found to be 2.14 mg per deciliter, and these are the drugs being prescribed. So this query came to the DIC, and the physician wanted to check whether dosage adjustment or dosing adjustment is required for cap fluver. Fluver is an antiviral drug, oseltamivir. So it is an antiviral drug which need adjustment in case of CKD patient. And here the physician has prescribed 75 mg twice daily. Okay, so what adjustment is to be made? So here we have to use the Cockcroft-Gault equation, where we have to monitor the creatinine clearance of the patient. So in normal adult, in males, the clearance is 110 to 150 ml per minute, whereas in female it is 100 to 130 ml per minute. So before checking the dose, we have to find the clearance rate of the patient. So for calculating the clearance rate, we have used the software, and where we have to enter the sex of the patient, the age of the patient, weight, and the creatinine. So after doing the equation, we have found the clearance is 21 ml per minute. Means for the 68-year-old patient with a weight of 52 kg and the creatinine level 2.14 mg per deciliter, the clearance was found to be 21 ml per minute. So this drug requires dosing adjustment. Now, how to do the adjustment? See, so this is the dosing adjustment to be done for the patient. So, see, our patient falls under the category of greater than 10 to 30 ml per minute, means under the third category, and this is not prophylactic treatment. See, she is admitted to pulmonology department, and she is having high grade fever and breathlessness, and her asthmatic condition is also worsened. So it is like the second column you can see, if the usual indication specific dose 75 mg daily, that is for seasonal influenza treatment. But here the patient is the patient is having the disease and we have to treat it. It is not a prophylactic method. So we have to adjust the dose of fluvir or oseltamivir to the 30 mg once daily. Here the physician has prescribed 75 mg BD. So now we have to adjust the dose as per this clearance level to 30 mg once daily. So this is how we handle the drug information queries and how we provide a rectified and restful answer to the person who is asking the query or who is depending on the DIC for the information. Now, this is a prescription, and does this prescription need any patient counseling? See, here we have the patient diagnosis Bell's palsy left and DLP, dyslipidemia. So, like the patient is prescribed with Visalon 20 mg. Then here I'll focus on Visalon. Okay, Visalon is repeated how many times? 4 times in this prescription. So we know steroids are the drugs which require dosing adjustment and tapering. Steroid can't be stopped all of a sudden. It should be tapered. The dose should be tapered. So the Visalon 20 mg tablet, it was prescribed 1.5. That means patient is taking 30 mg in the 7 days. Then again 20 mg he is continuing for 7 days. Again 10 mg for the 7 days, and at the last 5 mg for 7 days. So this prescription, if we are dispensing or if the pharmacist is dispensing the drug as such by putting Visalon 20 mg all together in a cover, means like 7 plus 7, if we are calculating, almost 14-20 mg tablet is being dispensed to the patient, means the patient don't know how to take or like when to be tapered or which dose I should start first, which dose I should stop. So here the counseling point to be kept in mind is like we have to inform the patient on the importance of tapering of steroid drugs. So we have to specifically mention like start 20 mg morning one and night half for the first 7 days. Then next 7 days you have to start the 20 mg. So he understands means from 20 to means sorry from 30 to the 20, so that tapering, then from 20 to 10, then 10 to 5. So by emphasizing the importance of this steroid tapering, patient adherence can be improved and we can expect a better therapeutic outcome too. Now, coming to medication reconciliation. So, what is reconciliation? Reconciliation, it is a process of collecting the previous history of patient with pertaining to the medication. I remember the case of a patient, a gynecology patient, and she was admitted to the hospital with the complaints of severe burning sensation while micturition and diagnosed with UTI. And in the hospital stay or during the hospital stay, she was continued with the drugs which was prescribed by the doctor. But what happened was that, like, she was already taking medicines for thyroid. But while in the hospital, she didn't inform about her old medication history to the doctor. And doctor uh, did not even prescribe the thyroid medication. And this patient also neglected that, thinking like it is not to be taken. And she omitted the drug for almost 1 week, and afterwards, what happened is like when she came for the follow up, she talked with the doctor like I was taking this medication, thyroid medications, before, and now I stopped because in discharge summary you didn't add this medicine. So, is it mandatory or is it necessary to take the medicine? So, it's the time when we came to know she was on medicine. So, here lies the importance of medication reconciliation. So, whenever a patient is admitted to the hospital, it is important to check their previous medicines and to make sure that those medicines are continued for the patient if it is required. Again, the second scenario is with insulin. So, uh, usually when the patient is on oral hypoglycemic agents, oral anti-diabetic drug, once he is admitted or hospitalized, often it will be switched to insulin. So again, while on discharge, if the insulin is omitted, again we have to continue the orals. But there are situations where the physician forgets to add the orals or the insulin, and the patient neglects it, and again develops like, or the insulin, again the patient meets up the hospital with high level of blood sugar. So this is the situation where clinical pharmacist should take his role, or the drug information center should act such that all medicines or whatever medicine is required to the patient should be made available and should be added to his treatment plan and should be continued. And especially earlier when we discussed like before the surgery, if we are stopping the drugs like aspirin, so after it's done, it is the duty of the physician to continue the drug. Or like if the physician omits it, it is the duty of the pharmacologist or the clinical pharmacist to inform and to add the medication such that the patient will not be affected at the any cost. Now, adverse drug reaction. This DICs also has a great role in monitoring of adverse drug reaction and to increase or emphasize the importance of reporting of ADR to make people aware about the ADR. This session in detail was covered by Dr. Shivmurthy sir. So I'm not going to explain in detail, but this is also the function which comes under the Drug Information Center. Now, providing training and education. As drug information center clinical pharmacist or clinical pharmacologist. It is the duty of each one of us to provide training and education to the healthcare providers. Means like we will be updated on the drugs, we will be updated on the guidelines, we will be updated on the WHO rules and guidelines. So it's our duty to inform other healthcare providers also who handles the drug. So most of the time, the drugs are administered by the nurses, but they may be lacking knowledge in diluents used, regarding the storage, after reconstitution, where to store the drug, or the drug can be used till how long, all such queries remains unanswered. So if we provide proper education and training to all other healthcare providers, we can resolve the problem of medication error, and we can improve the patient safety, and better medication adherence can be implemented. Now, antibiotic stewardship, even the Drug Information Center plays a great role in managing the antibiotic stewardship. In the last webinar of MPS, Dr. Jida Madam, she has explained in detail about antibiotic stewardship, everything. But here, as clinical pharmacists, through the DIC, even we have role to emphasize the importance of antibiotic, or to implement the stewardship program, antibiotic stewardship program, so as to control the source of infection and to educate the staff, then based to develop the policies related to antibiotics, etc. So with this I conclude my session, and I would like to give a key message like the same boiling water which soften the potato and which can harden the egg too. So it's not like we can't blame the physician's part, or we cannot blame the clinical pharmacist part. But if all the healthcare providers are working together, we can bring about better patient outcome. And even we have to develop the drug information centers such that the patient get benefited. Not only the patient, even the healthcare providers also. So better patient outcome, better treatment, everything can be implemented. So all, like my humble request, all should promote the drug information center in your institution such that the patient get benefited to a great extent. And always remember that there are no biologically safe drugs, only safe physician, nurses, and clinical pharmacists. Thank you.
Thank you, GGA. Audience, please, any queries? Audience, please, any queries?
Currently, no query we have seen, sir. I think,
Hello,
yes, sir.
sir. Very good evening, sir.
Good evening, sir.
Madam has precisely elaborated the topic, and I got a little bit interest to create to develop DIC in my institute, sir.
Dr. Shivkumar Shimurthy, may I ask a question, please?
1 minute, madam. I think Dr. Prashant is speaking one by
Hello.
one. Yes, sir. Dr. Prashant, sir, please go ahead.
Precisely elaborated the topic, and I got a little bit interest to create develop.
Dr. Shivkumar Shimurthy, may I ask a question, please?
Wait, madam. Wait, madam. One by one, please. Just 1 minute. I will go with the Dr. Prashant Mali first.
My
I think
question
you
is
can
to
type your
GG, madam.
question. Please type your question.
Hello.
Shivkumar Shimurthy,
And
may I
how
Madam,
many
would it
people are
possible
speaking?
to-
You can raise your hand, So, don't speak. Everyone should not speak at a time. Yes, sir.
Hello.
Prashant, sir, please go ahead, sir.
DG madam, would it possible to elaborate the infrastructural specifications as per the regulatory guidelines to develop DIC in the institute or in pharmacy institute? Is there any criteria,
Okay, so let me
guidelines?
just understand. So Dr. Prashant sir is asking about any guidelines for establishing the DIC in any institution.
No, sir.
Yes.
Like, Sir, the main thing to be kept in mind is like the DIC should be made accessible to the patient. So the better thing is like to start the DIC if it is in the hospital, to start it near to the pharmacy, so that the patient after getting his medicine directly reaches the pharmacy and gets his information. And the spacing is like, since I told like we should have proper arrangements and computers, everything, and we should have a clear space such that the patient feels free to interact with the clinical pharmacist. Means he should be able to speak with him. So that for that we have to set up the environment for that. And this we
Okay,
mentioned
okay.
many duties of the DIC, but all this, if it is operating in a single room, means it will be hard. So patient counseling should be focused separately, and other function has to be categorized accordingly.
Okay, thank
Another
you so
question,
much.
madam.
Yes,
Okay,
sir.
okay, okay.
Yes, sir. Please
Uh,
go ahead, sir.
is there any reporting to FDA by DIC in the institute, develop in the institution?
No, sir. No, sir.
No, no need to report the FDA and other regulatory agencies. Just we have to keep the
Yeah.
record to our educational
Yeah, yeah.
inspecting authorities
Yes,
to
sir.
show them the what we have did in our DIC.
Yeah.
Okay,
But, sir,
okay,
if
okay.
we are doing the
Hmm.
antibiotic stewardship, if the adverse drug reporting center is there, we have to report it. Like PVPI, we have to report the ADR, and antibiotic stewardship program is operating, means we have to design the guidelines of the antibiotic policy according to that. And even we can address all this concern in the PTC of the hospital, which happen. And according to that, they refine the policy of the hospital and try to implement the better outcome for the patients.
I think,
Okay,
like
okay.
just to, mention what Gigi has mentioned, I would like to, again emphasize that whatever the information you are giving to the patient, it should be recorded. Okay, because
Yes, sir.
patient
Yes,
can
sir.
come back to you saying that, you said this and I followed this and I ended up having the problem. So if you
Yeah.
don't have that
Right.
record, what you have said to the patient, then that will create more problems also. There can be
Yes.
legal issue also, like someone
Yes,
can,
obviously, sir. That's why I told we have to document whatever information we are giving to the patients. It should be documented.
yeah. So you
Right,
should
right.
maintain
Okay,
a track
okay.
record.
Thank you, thank you.
Yes. Okay. So second, I think Dr.
Okay.
Geraldine Sanjay has raised the question. So, Dr. Sanjay sir, can you please speak?
Good evening, all, and thank you for giving me this opportunity to ask Dr. Gigi. It's a very beautiful presentation. And what I'm concerned about is this pharma industrial complex, where Gigi, how can we trust the kind of information that the pharma companies are giving us? Because for them, it's a profit-making venture. The drugs that they're making, vaccines, etc. How do we, and the feedback and the adverse reactions that are reported are also important. But how do we trust these research articles on these various drugs that are coming into the market? Thank you.
Yeah, Gigi, you would
Like,
like to take the care? Yeah, please go
yeah,
ahead.
we cannot trust the leaflet or pamphlet information which is given by any manufacturers. So, from my experience, we never read that. It's not like I'm not blaming any manufacturer, I'm not pointing on any companies, nothing. But we use the resources from, like, we start the search from tertiary source, like from the books we start refining, and at the end we come to the updated software. That's why I emphasize the importance of updated software. Like, it's not like they update in 1 week or 1 month, where continuous updations on medicines are done, and there we will come to know everything in detail pertaining to the drug. We cannot, or we can never trust all this, but I emphasize all three sources should be utilized to answer a query.
Yeah, I think, like Gigi exactly mentioned about the primary source, secondary source, and tertiary source. And she also described about the, how the primary, secondary, and tertiary sources are derived. Like basically primary source means it is the research data directly coming from the investigator. And the secondary source means it is the review article that is coming out of the original article. Then tertiary source means it is the, which is the refined that is already there in the text. So like this, like it is there, derived in a systematic manner. And you know that, as the message is transmitting from one form to another form, it is getting, refined and refined. And sometimes it can happen that in the tertiary source, there can be a completely opposite wording that can be there. Okay, so one need to be very careful to go back to the original source and then verify what they are, saying. So this is just a word of caution, but you can trust, because if they have written based on the referenced article, they should display. It is the, it is the responsibility of the author of tertiary or secondary source to display properly. Sometimes, there can be skewed information. That's why generally we suggest you to go to the right kind of information. Okay, so if your source of information itself is wrong, then like anything can happen. That's why you should always go for the right kind of information. So as all of you know, we have already trained all the medical professionals that how to find the proper right kind of information, and you should use your judgment to go to another website, or even go chat GPT or any other. It's not the right kind of source. Okay, properly published by a peer reviewed journal or a well recognized publishing house, releasing a book or releasing a review article. So you should trust them because they are already peer reviewed and checked, and editors have a huge responsibility to do that. That's why it's very important for you to consider the right kind of information when you are either receiving or giving to someone else.
I think the patient should be the touchstone, no? Do no harm, do no harm. And I think that biofeedback is very important. Now, with artificial intelligence and so on, the care of the individual human person becomes very important. Anyway, thank you, Dr. Gigi.
Thank you. So, Shivendra, can you please unmute yourself and then ask your query? Shivendra? Yeah, please go ahead.
Yeah, first of all, it's a wonderful presentation. I just want to ask you something that regarding the indoor patients or the hospitalized patient, the clinical pharmacology plays a significant role, that's we all know. But the thing is that the major challenges is on the OPD patient or the outpatient patient. So could you just guide us with the few softwares or few techniques so that at minimum at primary health center level also, a pharmacist could guide a patient with the drug information center knowledge, because many of the infrastructure is not sufficient to provide any adequate support to build up the drug information center at very low levels. But the significant role of the pharmacist can play a major impact. So could you just guide us with a few software so that it would be impactful for the outpatient department also in terms of drug information center?
Okay, Gigi, you would
Okay,
like to say?
yeah, sir. Software in sense like I would like to add like we are aiming to provide patient safety for the common people. So even though we are in a modern world, but there are still people who don't know to use softwares, how and even how to read and how to write also, to tell the truth. Okay, but from our center, what we used to do is like we have made leaflets, like we the clinical pharmacists and pharmacologists have clubbed up, and we have made the leaflet in the common colloquial language which the patient understand. And so what we have done is like in the OPD department only, like pulmonology department, general medicine department and all, we used to keep the leaflet pertaining to how to use the medicine, especially insulin, inhalers, TB drugs, all such commonly occurring situation. We have developed the proper leaflet, that too in the common language, where the patient understands well. And what we does is we give our mobile number or like even the land phone number, and this phone will be available 24 into 7. It's like 24/7, our staffs will be rotating, means they will be having the phone, and even WhatsApp access is provided. Software developing you can do, sir, but the thing is like how much we'll develop. We have to respond to the query. It may be ADR related, drug interaction, it may be patient counseling related, which drugs they are using. So if we develop also, we have to teach them well in advance how to use the software, right? So that method we didn't incorporate, and I don't think it will be suitable. Even we have no WHO guidelines are there for TB treatment. Also, we have guidelines for gold guidelines. We have for asthmatic treatment, everything. But who is going to read that? Our emphasis is for the common people or to the patient. So I don't think all such things will work out.
Yeah, that's, I think, very practically what you mentioned is that, most importantly that the receiving end is not completely up and running,
Yes, sir.
basically. Like, we doctors, pharmacists or nurses, for some extent, we are all up and running with the information. And we can, nowadays, with the advent of mobiles and internet and all, I think we don't require a well-established drug information center to cater to us. If we are very clever enough, we can sit in the pharmacy, have a small outlet there, and if you with your mobile and with your computer and phone number, and you should be able to easily cater to the information. Most importantly, recording is something which is very important. Otherwise, I think, with the experience of the good experienced pharmacists and clinical pharmacologists should be able to address good number of queries with the available tools currently. I think even ChatGPT, a well-read, well experienced pharmacologist should be able to address very quickly, because they are already filled with knowledge, and they will be able to chart out which is the correct information, which is the wrong information. So in that way, quickly they should be able to solve. But I don't recommend all this. But only thing what I'm saying is that, like with the advent of all these available tools or the technology available, and we should be able to cater. But I take your point, Gigi. What you mentioned is that very commonly prescribed drugs leaflets, like
Yes,
instruction
sir.
leaflets, I think, which will solve majority of the problem. So that like
Yes, sir.
common is common, common sense is uncommon. That's what we have read and
Yes, sir.
understood. So it's always better to come with the commonly prescribed medications. Maybe 50 medications will be most commonly prescribed. So have the description or leaflets available, or some outlet, or you can have some boards
Yes,
directing
sir.
how to use in your section or drug information section, so that you can directly show to the patient. Or you can say flashcards also. You can have some flashcards available with you, and you can flash to the patients and then explain them. Okay, sir, thank you so much for asking this question, so that we are able to explain to everyone. And is there any further questions? Sir, Dr. Baswana sir, you would like to address the audience? Hello? Baswana sir?
Hello.
Yes, sir. Yes, sir. Concluding remark you can give, sir.
Once again, thank you, DJ, Ms. Gigi, Dr. J. It was wonderful and nice webinar, and you have told in detail about our drug information center, how to work and how not to work, and the what are the basic requirement is the manpower, basically in a government setup. Within private setup, so everything will be provided, but the information, that is the software, which is most important, necessary, as you told, that should be upgraded, software should be available. So thank you all, and thank you, Dr. Shivamurthy, giving this wonderful opportunity, and thank you all, audience, and thank you so much.
Okay, so
Thank you, sir.
I would like to maybe can you end Dr. Gigi your presentation, so that I will share my
Yes, sir. Yes, sir.
screen. Okay, so it's the
Sir.
time to honor our present us with a uh, uh, certificate. I would like to, show this certificate and put on record that, Gigi has presented this. So this is the certificate. I would like to everyone to clap her for her wonderful job by presenting this interesting talk. I would say some people are scratching. Who are these guys? So very nice. So congratulations, Gigi, for your nice presentation. It was well received. And
Thank you,
now I
sir.
would
Thank you.
like to present to certificate to Dr. Baswana sir.
Thank you.
Baswana sir, thank you so much for
Thank you, sir.
joining us. Thank you so much for joining us and taking part in this meeting and encouraging all the participants for their active participation. And so thank you so much. And I thank all the participants for for your valuable time. And I'm Dr. Shivamurthy, President of MPS Society, and I'm steering this MPS National Webinar. And we have crossed, we will cross very soon 3,000 participation registrations. And now, after this presentation is over, after the closing this call, I will be sharing the links in the WhatsApp group about the feedback and certificate downloading facility. So I'll be putting it very soon. And I want all of you to use this opportunity judiciously. And after downloading the certificate, I request everyone to share your certificate in the social media so that you are raising the awareness about the importance of Drug Information Center and also the kind of activities what we are doing through MPS Society. And at this time, I also would like to inform all of you that we will be conducting a certificate course very soon on biostatistics, which we will be introducing very soon. And we will be giving that opportunity to all of you to participate in that. It will be a brochure will be released very soon. That is one. Next one will be, we will be conducting MPS Con 2026 next year, most probably May to June around that. So I request everyone to be ready with your papers for presentation and also be ready for be ready with your interesting presentation so that we will be happy to have all of you in Bangalore, CD Timer at MPS Con 2026. Thank you. Looking forward to see you all next year and in our next webinar also. Okay, so we will be coming up with next topic soon. So please stay tuned. We will come back again. Thank you. Thank you one and all. Good night. Good day ahead. Thank you everyone for your valuable feedback and suggestions and active participation by asking good number of queries, and we will be able to come back again with additional programs. With this, I will close the call. Thank you.
Thank you. Thank you, sir.
Yes, sir.
Thank you, sir. Thank you, sir.
Thank you so much, sir. Thank you.
Thank you, sir.
Thank you.